Hi, and welcome to Mental Health Nursing. My name is Dr. Meredith Watkins, and this is 360 RN. This is the first lesson in a series of lessons on mental health nursing. It's a comprehensive training program on everything you need to know for mental health nursing, both for beginning bedside practice and for passing the NCLEX. Now, we've designed a study buddy workbooking system to help you get the most out of these lessons. These beautiful workbooks are going to help you learn and retain the most important information, help focus your studying, apply the content to practice questions, and give you tips and tricks for nursing school success. The link to the study buddies is going to be found in the description box below, but without further ado, let's get started. Now, in this lesson, we have 6 objectives. We're going to define and describe mental health and mental illness. We're going to discuss the history of mental health care. We're going to describe the stigma behind mental illness and the effect that that still has today on care. We're going to talk about the mental health continuum, describe factors that influence mental health, and then finally explain the purpose and usefulness of the DSM-5 criteria. So let's get into it. So before we can talk about what mental disorder is, we need to talk about what mental health is. Mental health includes our emotional, psychological, and social well-being. And when we have good mental health, it helps people cope with stress, recognize their abilities and strengths, helps them to learn and work, be part of a community, and have positive relationships. Now, mental illness, on the other hand, is a significant disturbance in our mental health, and that can be in a variety of different ways. It can be a disturbance in our thinking, also known as cognition, in our emotions, or in our behavior. And then that significant disturbance causes distress or impairment in our day-to-day living, in things like relationships and work and school. So let's get a pulse on how much of an issue is mental illness in the United States. Well, about a quarter of Americans are living with a mental illness, 23%. And half of those report having received some kind of treatment for their mental illness in the last year, whether that's counseling or medications. Depression is the most common mental illness, and we see more mental illness in females than in males. In terms of age category, young adults are at highest risk for having mental illness. And in terms of race or ethnicity, people reporting 2 or more ethnicities are at highest risk, followed by Alaskan Natives and American Indians. Now, when we think about mental health and mental illness, it's not like an on-off switch where you're either ill or well. It's actually a continuum, a spectrum from mental well-being to mental illness. And all of us are on the spectrum at all points, and we can be at different points in the spectrum at different parts of our life. And this is true for our mental health patients as well. There are going to be times when they're doing better and they're going to be doing worse. And it's up to us to assess where they're at on this mental health continuum so that we can provide the appropriate resources they need at that time. The best point of mental well-being is considered thriving. A patient who is thriving is using their coping skills and is optimally functioning. They're in control, they're calm and steady, they can have a sense of humor, they're sleeping well, they're physically well, and they have a lot of resilience and self-care. The next step down from thriving is surviving. And this patient is going to have mild or temporary distress. This may become from personal stress or work stress, or it may be some kind of acute stress that they're facing. Someone who is surviving is going to be worried, irritable, and angry, have a hard time sleeping. They may be avoiding situations, they may be critical, and they might experience social isolation. And at this point, the patient's able to resolve this level of surviving through peer support and self-care and maybe some counseling. The next phase down from this is struggling. Someone who's struggling is having moderate and persistent distress, and it's having impairment in multiple areas of their life. In other words, it's affecting their work life, their social life, their personal life, their school life. And this can be from different trauma, from exhaustion, from grief, or from moral distress. Patients who are in the struggling point of the spectrum may feel panic or rage, have a hard time sleeping, they might have guilt or shame, their relationships would be suffering, and they complain of somatic complaints. And this level of struggling really requires clinical guidance and support, typically in the outpatient setting. And finally, a patient in true mental health crisis can happen from severe distress or psychosis or any other mental health disorder, like schizophrenia or bipolar. This can happen from PTSD or trauma, anxiety, and substance abuse. And patients in crisis may experience thoughts of suicide, psychosis, or delusions or hallucinations. They may feel hopeless, feel lost, and feel out of control. And many of these patients will require inpatient hospitalization to resolve this level of distress. Let's talk about the history of mental health care in the world and how we've gotten to where we are today. So in order to understand where we are today, we have to look back. And if we look back pre-1700s, mental illnesses were really attributed mostly to demonic possessions, perceived as being punished by an angry god, or as a result of witchcraft. And the treatments for people with mental illness before the 1700s were things like exorcisms, medicinal drinks, and even drilling holes into the skull to release spirits. And sometimes patients were even executed as being perceived as witches. Now, in the 1700s, we start to see our first glimpse of modern mental health care, and that was in the form of asylums. But the point of asylums when they first started wasn't to really help patients, it was rather to remove them from society. And patients, unfortunately, were treated horrendously in these asylums, sometimes chained to beds or put into dungeons and facing beatings. Now, our first mental health influencer for this course is Dr. Philippe Pinel from France. And in the late 1700s, he started advocating for better treatment of hospitalized patients in the asylum. And patients were allowed to leave the asylum and get out into the community a little bit. The next important influencer to talk about is in the 1800s, and that's Dorothea Dix. Dorothea Dix was the superintendent of Army nurses in the Civil War, but she's most known for advocating to the U.S. government for mental health institutions. In fact, she is known for founding over 30 mental health institutions, and some of them being the first ever in America. Now, in the mid to late 1900s is when we start to finally see this shift into what we now know as the mental health organizations and systems that we have in the United States for care. And that started in 1963 when President Kennedy signed the Community Mental Health Act, which opened up community-based mental health centers in America. Then in 1990, President Bush declared it the Decade of the Brain and signed into law the Americans with Disabilities Act as a landmark bill prohibiting discrimination against people with disabilities, and that included people with mental health disabilities. The next major law came in 1996 when President Clinton signed the first mental health parity law to begin addressing disparities in the coverage of mental illness, because up until this point, lots of health insurances were providing medical insurance, but not covering mental health care. And around this time, there was also different conferences and work groups set up at the federal government to start exploring the stigma around mental health and how, as a country, we could do better. The next major law was in 2004, when President George W. Bush signed the Mentally Ill Offender Treatment and Crime Reduction Act. This provided resources for communities for alternatives to incarceration for youth and adults with mental illness and co-occurring substance use disorders. And the last two laws that you're seeing here on your timeline are the Mental Health Parity and Addictions Equity Act and the Affordable Care Act from President Obama. Now, these last two acts continue to expand on coverage and require insurance coverage for mental health, just like they do for medical health. So you can see that we've come a long way in just 150 years. And while we've come a long way, we still have a long way to go. And there are certain factors that influence mental health and mental health outcomes today. These include things like bias and stigma, genetics plus environmental triggers, social determinants of health, adverse childhood events, also known as ACEs, protective factors of childhood, and health disparities. We're going to talk about each of these factors separately. The first factor that influences mental health is bias, and bias can be either implicit or explicit. Explicit bias means you know you're biased. Implicit bias is more dangerous because it means you don't even recognize the bias that you have. And these biases can influence the way healthcare providers and nurses treat patients. So it's important for us to examine our biases, both explicit and implicit. Stereotypes means assuming things of someone based on some kind of label that they had. And unfortunately, people with mental health illness, especially serious mental health illness like schizophrenia or bipolar, often are stereotyped. And prejudice goes along with this. Prejudice means prejudgment, judging someone before you even know about them. And unfortunately, because of bias and stereotypes and prejudice, there can be discriminatory practices, even though there's laws to prohibit that. Patients with mental illness often have a harder time getting jobs and getting into schools. The next factor that influences mental health is that of stigma. Stigma is the overall opinion of mental illness, and for years, if not centuries, there's been stigma around mental illness. I mean, think about how mental illness was treated before the 1700s. It was considered to be demonic possession or witchcraft. And so there is stigma in a variety of ways. There can be public opinion of mental illness, the historical view of mental illness, one's personal view of mental illness, and then the overall healthcare view of people with mental illness. And this stigma can really impact patients and prevent them from even wanting to seek care. Sometimes patients have a personal stigma of mental illness, and they may consider it a weakness or something that they're ashamed of and not something they want to admit. People in the healthcare system can have a stigma about people with mental illness. In fact, patients with mental illness are more likely to be disregarded for their pain or have their medical conditions even treated seriously. And so this negative view of mental illness as something that is a weakness, something that someone should be able to control or just snap out of, has really had a detrimental impact on our care of people with mental illness, both in seeking care and the treatment that they get. And it's important as we consider going into nursing, any stigma that we have around mental illness and how that impacts the way we treat patients. The next factor that influences mental illness is the diathesis-stress model. So diathesis just means genetics, and stress means some kind of environmental trigger. And so for many mental illnesses, medical researchers have determined that a lot of times they're triggered by this component of having a genetic predisposition, some kind of family history or gene, plus some kind of genetic or some kind of environmental triggers. And so those genetics can either be from a family history, things that were passed down to you, or it can even be de novo mutations, which means a genetic mutation that happened for you but wasn't part of your family history. So in addition to genetics, there's some kind of environmental trigger. These triggers can be things like abuse, stress, lack of access to healthcare, problems in their community, home life situations, or financial struggles. So when you have a genetic predisposition plus an environmental trigger, it sets you up to more likely have a mental illness. Did you know that the family that you're raised in the community that you lived in, can impact your outcomes with mental illness? These are called social determinants of mental health. And things like income, housing, education, employment, abuse can all impact your likelihood to get a mental illness and then the outcome that you have with that mental illness and how severe it gets. And so patients with lower income, poor access to housing or no housing, low education, unemployment, history of abuse or neglect, having unsafe neighborhoods, lacking a support system, or patients facing discrimination or systemic racism are more likely to have mental illnesses and have poorer outcomes from those mental illnesses. As nurses, it's important to recognize these social determinants of health as risk factors for our patients and screen patients for these social determinants of mental health so that we can provide early screening and intervention to give patients equitable and excellent outcomes. Perhaps the most significant cause or influence into someone getting a mental illness is their childhood experiences, especially negative childhood experiences. We call these adverse childhood experiences, or ACEs, and they may be the biggest contributing factor to developing mental health illnesses down the line. Adverse childhood experiences are negative experiences that dramatically impact a child's mental wellness as well as their development. This includes things like traumatic events faced in childhood from ages 0 to 17, experiencing violence, abuse, or neglect, having a family member die of suicide, being a witness of violence, having a caregiver with a substance use disorder or mental health problem, or having a caregiver who's incarcerated. And there's a direct proportion to the number of ACEs a child faces and the higher risk that they have for developing mental illness. Now, anyone facing ACEs as a child has a higher risk for developing mental illness, but there are certain vulnerable populations that, if they have ACEs in their childhood, put them at even greater risk of developing mental illness. So a patient who experiences adverse childhood experiences and has any of these other circumstances are at much higher risk for having a mental illness. This includes people in the LGBTQ+ community, people making less than $15,000 a year, people with less than a high school education, if they're unemployed, American Indian, Alaskan Native, and people of multiple ethnicities. All of these put patients at even higher risk of having poor outcomes in mental illness related to ACEs. And the scary part of this is that these ACEs don't just affect mental health, they affect physical health as well. In fact, you can see ACEs have poor outcomes for patients in a variety of health settings, including their chronic health conditions, health risk behaviors, social outcomes, and mental health and substance use disorder problems. Let's talk about each of these directly. Patients who experience ACEs are more likely to have chronic health conditions. This includes things like coronary heart disease, strokes, asthma, COPD, cancer, kidney disease, diabetes, and obesity. Patients who have ACEs are more likely to have health risk behavior. This includes smoking, excessive alcohol use, substance misuse, physical inactivity, sexual risk behaviors, and suicidal thoughts and behaviors. Patients who have had ACEs are less likely to have health insurance, they're more likely to be unemployed, and they're more likely to have less than a college level, a high school level education. And finally, it's no surprise that patients with ACEs in their childhood are more likely to have a variety of mental health disorders and substance use disorders, including things like alcohol, opioids, and tobacco. So you can see that the consequences of adverse childhood experiences affect someone's entire life, and it's important as nurses that we recognize ACEs and we do our part to prevent ACEs in the community. Now, the good news is that there are protective factors that can help prevent having the adverse outcomes from ACEs. So you can think of this kind of like a scale, and if the adverse childhood experiences outweigh the good things in the child's life, they're more likely to experience these negative outcomes. But if a child has some protective factors in their life, like stable families, nurturing relationships, role models or mentors, maybe that's a coach or a teacher at school, positive friendships, success in school, if their caregivers have college degrees, if their families participate in positive activities together, and if their families have access to things like housing, preschool, medical services, and community connectedness, these can protect against the negative, harmful effects of adverse childhood experiences. So as nurses, we want to encourage healthy families, mentors, and healthy communities. Another factor that influences mental health is that of health disparities. There are certain vulnerable populations that are more likely to experience poor mental health outcomes. This includes people in rural areas, and that's often due to a lack of access to specialty providers. People in marginalized communities like the LGBTQ+ community or the BIPOC community. Veterans and incarcerated individuals are all at higher risk for poor mental health outcomes. Nurses can help reduce these disparities by providing patient-centered care, care that's meaningful to the patient and helps the patient reach the goals that they've identified. It also means providing culturally competent care, taking into the perspective all of the patient's values and beliefs and spiritual understandings that make up who they are and the things that are important to them. Having a diverse workforce so that patients can see people who look like them when they're providing care. It helps develop trust and builds rapport. Advocacy, advocating for vulnerable populations and for community health. Policy changes to increase access to mental health resources in the community. Helping to combat systemic racism, which has a negative impact on patients and can cause mental illness. And then finally, examining our own biases and making sure that we check those at the door so we provide patients with equitable and quality care. And the last topic to close out our Mental Health 101 lecture for today is that of the DSM-5. The DSM-5 is a diagnostic manual that helps psychiatrists and medical doctors to determine what mental illness a patient might have. The DSM-5 provides categories of mental illnesses and categorizes them by similar manifestations. It provides a common language for mental health care and gives specific parameters on what qualifies for each mental illness. So there would be specific qualifications for something like bipolar 1 versus bipolar 2, schizophrenia, borderline personality disorder, and so on. It's a great resource to understand the clinical manifestations of each of these diagnostic medical illnesses. Now, remember, as nurses, we're not diagnosing these, but it's important that we understand the DSM-5 so we can understand the diagnostic criteria. The other thing to note about the DSM-5 is that it does not provide treatment recommendations. It is a diagnostic manual only. That's going to wrap it up for Mental Health 101 for Nurses. Come back for next time. Thanks so much for studying with me today. And remember, you are smart, you are capable, you are loved, and you got this. I'll see you next time.